I'm going to invite the tripartite of Kerry, Silvana, and Elaine to lead us with their presentation on clinical nurse specialists as catalysts for quality improvement in Northern Health.
Thank you. We are excited to shine a light on the pivotal role of the clinical nurse specialist as a catalyst for quality improvement within Northern Health. I am Silvana, and I serve as a clinical nurse specialist within Northern Health Perinatal Service Network.
My name is Kerry. I am the clinical nurse specialist for IV therapy and vascular access in Northern Health. And I just want to apologize in advance. I had to relocate due to a power outage, so excuse any feedback or anything from my background. Thank you.
And I'm Elaine Veldman. I'm the clinical nurse specialist for skin, wound, ostomy, and continence in Northern Health. And we would also like to acknowledge Angela DeSmit and Ebolia Augustin, who for their contributions and for their great support with the development of this presentation today. We also want to begin by acknowledging that while we all gather virtually, the co-presenters today are attending and presenting from the traditional territories of the Lheidli T'enneh and the Tsimshian nations.
So today we will share how clinical nurse specialists put advanced practice into action by shaping care, supporting teams, and driving quality improvement across Northern Health. To start, we will take a closer look at what a clinical nurse specialist is. Then we will explore how we are practicing within Northern Health, guided by the CNS framework. Finally, we will share some clinical examples that highlight the unique expertise and impact these roles bring to patient care, teams, and the health system. A clinical nurse specialist, or CNS, is a registered nurse with expertise in a specialized area of clinical practice with advanced nursing education preparation. Areas of specialization may focus on a specific population, care setting, disease, or health condition. CNSs serve as a resource and expert for clinical teams, helping to translate evidence into everyday practice. The Canadian Nurses Association describes the CNS as agents of change, improving safety, promoting positive health outcomes, and supporting a more sustainable, efficient healthcare delivery. In Northern Health, each CNS role is unique. Silvana for perinatal services, Elaine for skin, wound, ostomy, and continence, and myself for IV therapy and vascular access. Each role is structured differently within the organization, either being embedded in a specific service network, established across care settings, or being a more grassroots initiative. Together, these roles bridge direct clinical care and system-level improvement, translating advanced practice into tangible impacts for patients, families, teams, and organizational processes. CNSs apply their specialized expertise to catalyze change and enhance quality of care. There are 4 pillars in the CNS's advanced practice framework: clinical care, systems leadership, advancing practice, and evaluation and research. These 4 pillars illustrate the full scope of how the CNS practice contributes to improved outcomes and advancing quality. Clinical care is at the heart of the CNS role, encompassing both direct and indirect care. Direct care includes the consultation and support we provide to nurses and interprofessional teams for complex patients or clinical situations, guiding practice, promoting evidence-informed care, and helping others build their clinical confidence. This pillar captures how CNSs translate their advanced expertise into practice change by identifying gaps, mentoring staff, and leading quality improvement initiatives as we strengthen clinical capacity across the system.
System leadership, the next pillar in our framework, requires seeing the bigger picture. It is the ability to lead and manage change across the healthcare system in ways that improve patient care and outcomes within the region and provincially. As a clinical nurse specialist, this means using clinical expertise to identify and address issues that span departments, care settings, and service networks. It requires understanding and advocating for how people access care, how they move through the system, and how care is delivered. Effective system leadership depends on building strong relationships and collaborating with diverse key groups. That includes patients and families, our fellow nurses and educators, our interprofessional teams, managers, and executive leadership. The goal is to empower others to drive positive change, evidence-based change across the system.
The clinical nurse specialist plays a leadership role in shaping and improving nursing practice. They support nurses in growing professionally by helping them build confidence and competence in their roles. A key part of this leadership is maximizing the scope and the depth of nursing practice. This means helping nurses work to their full potential, using all their skills and knowledge to provide the best care possible. CNS also focus on capacity building, strengthening the overall ability of the nursing team to meet patient needs, especially in complex or high-demand environments. All of this is grounded in evidence-informed practice. CNSs ensure that care decisions are based on the latest research and best practices, which leads to safer and more effective patient outcomes. CNSs lead quality improvement initiatives, identifying system barriers and optimizing processes. They conduct program evaluation to assess the efficacy and value of the new clinical pathways and resource allocation. The CNS translates data into applicable knowledge, ensuring continuation of optimization of care. They are experts in translating complex findings into practical clinical guidelines, protocols, and educational materials. They foster a culture of inquiry by promoting research utilization and critical thinking among staff. In essence, the CNS uses evaluation to prove the value of current care practices and research to propel the future of clinical practice while maintaining excellence and safety.
Each of us are new to our advanced practice CNS roles within Northern Health. We are just beginning to learn and develop these framework competencies to guide and shape our roles, work, and impacts. We would like to share a few examples that bring the CNS role to life and highlights how some of our early work is directly impacting quality improvement within Northern Health. The first key highlight that I would like to share is my leadership in phase 1 of a regional initiative, which focuses on IV therapy standardization. During this phase, a comprehensive environmental scan was conducted, consulting with 41 clinical leaders and specialists across Northern Health in level 3, 4, and 5 hospitals. It also included a review of services offered through our 9 community oncology networks and led to the identification of key service gaps across the care settings. These findings have helped us identify key priorities and will guide the next phase in the initiative as we work with leadership to plan and implement strategies that strengthen IV therapy services across Northern Health. The second key highlight is the rapid clinical response I led during the BD PICC line fractures that began emerging last fall. As incidents increased and Health Canada issued a product recall, I supported an at-the-elbow response to mitigate safety risks and ensure ongoing service delivery. To avoid service disruption, UHMBC became the second site in BC to implement the Teleflex system. shown here during our ribbon cutting. Beneath it, you'll see an image of a fractured PICC line, which illustrates the urgency and clinical risk that accelerated our decision. During this transition, I provided frontline education, developed guidelines, and collaborated with PHSA, risk management, and other health authorities. This CNS-led response ensured uninterrupted vascular access service and reduced clinical risk during a time of significant uncertainty.
One key area of my work has been supporting implementation of a new required safety practice, optimizing skin integrity from Accreditation Canada. This RSP builds on previous standards for pressure injury prevention and now encompasses the prevention of all skin injuries. In response to Accreditation Canada's specifications, I am leading Northern Health's updates to align with the new RSP. Some of that has included enhancing risk identification processes, and collaborating provincially to create a tool with screening questions. Also supporting knowledge mobilization from our clinical practice standards into practice, and meeting with leadership to support this in new care settings for Northern Health, as well as standardizing products and education to promote skin integrity and prevent injuries. This work also involved provincial collaboration with the Patient Safety Learning System and the development of provincial guidelines to improve skin injury reporting and identify opportunities for quality improvement based on data analysis. The CNS role has been and will continue to be instrumental in the ongoing work to provide safe, quality care every day and support Northern Health's readiness for future accreditation surveys. A second area of focus for my work has been the enhancement and expansion of Pixelaire, which is Northern Health's electronic wound documentation application used since 2011 by community nursing, interprofessional teams, and nurses specialized in wound, ostomy, and continence in Northern Health. Recognizing the benefits of an upgraded version and expanded functionality, I have collaborated with IMIT, created a working group, and we successfully obtained funding for this expansion. Together, to date, we have conducted clinical testing of the new software. We've nearly completed a privacy impact assessment and updated clinical practice standards and learning resources to help support implementation. Pixelaire is an important tool for documentation and a referral pathway to our nursing specialists, but it also serves as a very valuable data source, enabling us to track wound trends, healing times, associated costs, and plan clinical care. The enhanced Pixelaire version is scheduled for implementation in Northern Health, we're hoping in November.
As a clinical nurse specialist in perinatal care, I serve as a key resource within our perinatal community of practice. This initiative is designed to raise the voices of nurses across the network by ensuring their insights inform both current operations and future strategic priorities. I work closely with the clinical nurse educators to address concerns raised by point of care staffing, fostering a collaborative and responsive approach to emerging clinical needs. In alignment with the strategic priorities of the perinatal service networks, I have assumed leadership roles in several critical initiatives. One of them is leading efforts to standardize and accredit the Northern Health Perinatal Specialty Education Program through the Canadian Nurses Association. This initiative aims to establish a credible, consistent educational pathway that will ensure all perinatal nurses across the region receive high-quality, evidence-informed education aligned with national standards. By building a reliable and standardized educational pathways, we are better positioned to maintain service continuity, particularly during periods of system pressure, such as staffing shortages, high patient volumes, or unexpected service disruption. Standardized training enables staff to adapt more easily across sites by helping to prevent interruptions in care delivery. Furthermore, the Perinatal Service Network has identified the absence of a standardized perinatal quality review process as a critical gap across the region. Proactive and structured approach to quality review is essential for the early identification of system-level risks and the implementation of timely, effective interventions. In response, I am leading the development of a regional framework and toolkit designed to support consistent, evidence-informed quality reviews. This initiative will facilitate the integration of interdisciplinary recommendation into nursing practice and drive continuous quality improvement across all sites. This is the end of our presentation. Thank you very much for your attention.
Thank you so much. You were right on time. Thank you so much. So we're going to take a few questions. Benita has a question.
Yeah, hi. Thanks for that. That was great. I'm not sure if I missed it, but I'm just curious. Like, what is a qualification to be a CNS? Like, is it a certification or is it, combination of education experience? Yeah, I'm just curious what qualifies someone to be a CNS.
I can answer that. The recommendation of the Canadian Nurses Association is that a CNS, a nurse with advanced practice, would hold a master's or a doctoral degree within that specialty.
And I will add also, Benita, or an equivalent of experience, system-wide experience. And also provincially in BC, we are striving to have everyone at a master's level preparation. We recognize that sometimes that we have to balance the experience and the expertise with the access to education. So we have taken a more liberal stance in which we prioritize education, experience over access to education for right now as we start these positions.
Anybody? We have a minute or so for another question. Is that an additional question? Oh, there we go. Vanessa? Then we'll
Thank
go to
you.
Sandra.
Can you hear me?
Yes.
Okay, I don't know why my camera's not working. Anyways, just a quick question. Thank you so much. I think the CNS roles have just become so important in Northern Health, and of course I'm biased with the Perinatal Service Network and that work, and just wondered what is the opportunity to expand clinical nurse specialist roles in other clinical areas in Northern Health? Has there been any looking into that opportunity?
Yes, I think active recruitment is undergoing right now by Northern Health. Given the financial restraints we're all in this year, things might be a little bit slow, but I would think that and recommend that clinical nurse specialists are hired within all of the service networks within Northern Health, and areas that do not belong to a service network but have the significant need of it.
Okay, thank you so much. It seems the person who had another question dropped their hand, and we just have 1 more minute to get the next person set up. So if there are additional questions, I see there are additional questions in the chat. Maybe the presenters can try to respond to those directly into the chat. I'm going to invite Benita to get set up and get their presentation ready. And we are looking forward to hearing about determining counseling self-efficacy of rural mental health clinicians. Benita, take it away.
Okay, there. Can you hear me and see my slide? Perfect.
Yes.
Okay, I'm just going to move folks over. All right, welcome everyone. My name is Benita Morvan. My job is professional practice lead, one of the professional practice leads for allied health in Northern Health. And that was the role that prompted my interest in this topic. But I am a registered occupational therapist, clinical instructor with UMBC in the Masters of OT program. But this project was for a Masters in Rehabilitation Science that I completed last year with UBC. Under the supervision of Dr. Ellie Park. And I'm calling in today from the unceded ancestral and traditional territories of the Lheidli T'enneh, whose traditional territory includes the city of Prince George. So the state of mental health and substance use is a concern in northern BC. Our suicide rate is 1.4 times higher than the provincial average. We've had the highest rate in BC of fatalities from the toxic drug crisis. And as we all know, providing mental health services in rural areas is challenging. And one way to address this is incorporating mental health clinicians into primary care settings. So we've done that in Northern Health by creating interprofessional teams connected to a doctor's practice. And on these teams, we have mental health and substance use clinicians. Which then leads to the question of self-efficacy. So we don't know much about this group, this profession in Northern Health, and we do not know how they perceive their effectiveness. And so that led to my 2 research questions. And I think considering the significant personal and societal costs associated with mental illness and substance use, and considering the significant investment that's being put into this area, I think it's important that we understand more about them. So as part of my literature review, so globally, there has been a move to integrate mental health into medical settings that increases access to care. It shows improved clinical outcomes. However, mental health clinicians often lack the training to work with patients in primary care settings. However, it can be successful if the treatment matches their competency and if they have clear standards and guidelines. So further, as part of my literature review, I looked at rural and remote clinicians. So when we hone in specifically on mental health clinicians, literature tells us, as I think we all know, mental health options are usually limited in rural areas. So clinicians often serve as generalists. They may lack local specialty referrals, and they often receive referrals for cases that they may not feel fully equipped to treat. And they have to balance, the patient's needs while acknowledging their own limitations. And when we brought in to just allied health in general, who work rural and remote, we know that they have a lot of autonomy, which has some positive aspects, but it can also cause stress, burnout, and lead them to leaving their positions. And some factors that can increase their self-assurance include things like, manager support, professional development, and clearly defined roles. Counseling self-efficacy is defined as a clinician's belief in their ability to effectively carry out counseling interventions and positively impact their clients' well-being. Poor self-efficacy can predict burnout, whereas high self-efficacy can predict things like, performing well in the job, commitment to profession, ability to advocate for others. Counseling self-efficacy can also be increased through external influences, so things like quality training, job shadowing, and coworker support. So I think this makes it a valuable factor that we can measure and modify. And before I started my research study, I also gathered some data around clinicians in Northern Health. And so according to the job description, they require a bachelor's degree in allied health, behavioral, or social science field relevant to the position. It's an unregulated profession, so that means they don't have a regulatory college like physiotherapists or nurses. And one of the duties listed on their job description is functioning as a primary clinician, providing short-term clinical counseling and crisis intervention. And at the time of my study, there was, there's no regional governance or educators. Currently now, we do have one substance use educator for Northern Health. And then the other column shows some statistics at the time that there were 89 working in primary care, as well as some of their the vacancy rate there. And so the literature, in summary, gives us a background on counseling self-efficacy, which in a lot of the literature is graduate level or licensed counselors. A lot of countries, they are licensed. And we have some information about, rural mental health clinicians and some statistics from Northern Health. But there was a gap in the research for my specific population of interest, which was the perceived counseling self-efficacy of bachelor-trained, unregulated, mental health and substance use clinicians working in Canadian primary care, rural and remote settings. So for my methodology, I used a survey design. My participants were mental health clinicians. Again, there was a variety of titles that could be used, such as addiction therapist and other ones like that. I excluded team leads and managers. If a clinician worked in multiple settings, including primary care, then I included them. But if they only worked in inpatients or specialized services, then they were excluded. And I used the Qualtrics survey platform, as well as convenient sampling. And I used email and the MyNH to advertise. And so my survey consisted of two parts. The first part was a survey to collect professional and practice characteristics. I purposely didn't ask really detailed demographics info just to reduce the risk of re-identification. And then the second part is something called the Counselor Activity Self-Efficacy Scale. So it's a valid and reliable tool. It has 59 items covering 3 domains. So basically, participants are asked to rate their confidence in their ability to perform a specific task or manage a specific scenario. So 10-point scale ranging from no confidence, 0, to complete confidence, 9. All right, so let's delve into the results and discussion. So I'd like to point out the educational diversity. So 37%, as noted up here, have a degree as required by the job description, but 30% have a bachelor in social work. And social work is a regulated health profession. So potentially the role of, the presence of social workers in mental health and substance use positions could contribute to vacancies in the social work positions. As well, 20% have a master's. And so the diversity in these educational backgrounds could lead to, a variety of approaches, perspectives, confidence, and may explain some of the variance that we see in self-efficacy. When we look at experience, so 59% have more than 5 years of experience in mental health and substance use. And that was a big surprise for me. This could explain the relatively high level of self-efficacy that we see in the cases results. However, there's still a notable portion of clinicians who are relatively new to the field, and self-efficacy does improve with experience. Another point is that many clinicians do not receive clinical supervision or receive it less than monthly. And this could be a point of concern as regular supervision improves counselor self-awareness, self-efficacy. It enhances rural allied health job confidence, satisfaction, and retention. And finally, the varying caseloads among clinicians, could raise questions about workload. Again, we're not sure here if some have smaller caseloads because they have more complex clients, or, we're not sure of the reason here, but we can see that there is a variety here. And it's just important consideration that, workload can have an impact on emotional exhaustion and depersonalization. So now let's discuss the results from the Counselor Activity Self-Efficacy Scale. So helping skills refer to fundamental communication competencies. And while they're considered basic skills, they're not necessarily easy to perform, but they are essential. They form the core components of a counselor's responsibility. And so helping skills exploration, that's things like listening, restating, and here respondents reported high confidence, so over 7. As an average, with a low standard deviation. So low variability in responses. And the other two, insight and action, had similar scores, so kind of moderate to high confidence. So insight is foundational communication skills that facilitate a client's deeper understanding of themselves and their issues. And action is things like giving homework, role playing, so specific interventions to address clients' needs. So based on this analysis, overall, it seems that clinicians are, most confident in their exploration skills, and overall, they're moderately to strongly confident in their helping skills. Session management is the perceived ability to organize and direct the counseling session to meet goals. So keeping the session on track, knowing what to do or say next, helping a client talk about their concerns at a deeper level. So for 9 out of 10 of these questions, participants rated themselves a 7 or higher. So indicating a high level of self-efficacy, which does align with findings in literature. And then the last domain is counseling challenges. So while helping skills and session management skills are context-free, the counseling challenges ask participants to rate their self-efficacy for specific client types or scenarios. The scores here ranged from 5.98 to 8. So again, indicating clinicians generally feel confident. You can see here where they rated themselves as highly confident. So things like clients that were depressed or extremely anxious. And the one they rated as it being least confident was working with a patient who's sexually attracted to you. So based on this analysis, it seems that, clinicians do feel moderately to strongly confident in their ability to handle these challenges, but there was more variability in these responses. And again, that could be due to, what we saw, the difference in education, the difference in experience. And that is something to consider because, depending on the clinician that you're matched with as a patient, right, you might get someone with a different level of confidence. Additionally, challenging clients can lead to greater burnout. And so targeted training for working with these complex clients could reduce the likelihood of burnout. So some implications for practice or some, suggested potential actions or recommendations. I think Northern Health could capitalize on the experience and education levels that we do have. Things like mentorship, job shadowing, communities of practice. Could also consider creating positions that require a graduate degree. They could take more complex clients. They could support new graduates, or consider creating leadership and support positions, such as clinical leads or educators. Literature tells us that career development opportunities are important for allied health, and when they lack opportunities to develop careers or specialization, this negatively impacts their intention to stay in rural areas. So it can improve self-efficacy and retention. The evidence in counseling supports clinical supervision. I think, and our respondents reported limited clinical supervision. However, there are a variety of models that could be incorporated, such as peer group clinical supervision. And finally, another implication is that clinicians could consider using the cases themselves to self-evaluate their own practice and develop their own learning plans. Finally, the organization could consider some targeted education. Self-efficacy does improve with quality training. All these issues I have listed here are basically ones that people rated under 7. And so the organization could consider targeting education in these specific areas. So a couple limitations. While short-term counseling is described in the job description, some questions in the cases would not pertain to every clinician's practice. Some might really focus more on case management. Some might just do a little bit of motivational interviewing, where some really do a 45-minute counseling session. So it might not relate for all clinicians, all questions. And another limitation was that I used convenience sampling. So in conclusion, the study highlighted the moderate to high levels of counseling self-efficacy among rural mental health and substance use clinicians in Canadian primary care settings. Nevertheless, there was variability in confidence level, indicating a need for targeted interventions to support standardized provision of care. Some ways to address these gaps could include training, clinical support, mentorship, and creation of leadership positions. And then I think future research could focus on exploring the relationship between self-efficacy and professional characteristics, as well as qualitative research to really understand clinicians' perspectives. And if you would like to see my references, you can click on the QR code. I'd like to thank Ellie Park, my supervisor, and Abolia, who was my agency sponsor during this project.
Thank you so much, Benita, for that inspiring presentation. Very, very insightful. We have few chances for questions. Suzanne, take it away.
Thank you, Benita. Really, really interesting, actually, results. And I kind of appreciate sort of a different perspective on that pool of really important practitioners that we have in Northern Health. I'm wondering if your data allowed you to do any sort of subgroup analysis, like breaking out between the bachelor versus master trained, or based on no. Okay, because that would be quite interesting, right? To just see if we could dig in a little deeper and kind of tease out the experience base and the training. But yeah, okay.
No, exactly. Mine was just a purely level 1 study of just gathering data. I think, it would have been interesting to see, because you would assume those with, maybe a master's or more experience would be more confident, but that would be an assumption, right? We don't, couldn't actually address that in the study.
Next study 2.
Very good challenge. Yeah. Hopefully you're up for it. Anybody else with a question or comment? Tammy.
Yeah, thank you. Thank you so much for this presentation, Benita. I'm just curious if there was anything that really stood out. I know that like you said, this was a level 1 study, but I'm wondering if anything really jumped out or stood out as surprising to you.
Yeah, I think I was actually surprised at the level of confidence and self-efficacy. I think just from anecdotally and working in professional practice and the things I was hearing, I thought it would be lower. But then I was also really surprised by how much experience people had. I think 46% had more than 10 years. Almost 30% have a master's. So that was really surprising. And I think that, kind of helped to give a better picture to who are these people in these roles. Yeah, thanks, Tammy.
Yeah.
Very interesting, fascinating data, fascinating findings. So what is the next step now that you have these findings? What are you going to do?
Well, right now, I'm done my master's and no desire to do my PhD at this point. I am back in professional practice in that role. So, and now I have a colleague who actually leads social work and disciplines allied to social work. So, potentially, potentially sharing with the mental health and substance use service network, or seeing if, anyone else in Northern Health is interested in these findings could be another step.
Thank you so much for the presentation. Round of applause. And now we will switch to our third and final presenter, and that will be Esther. So if you can invite Esther to set up your presentation. And yeah, I can see your screen. Everything looks good. Whenever you're ready, you can take it away.
Awesome. Thank you so much. And thank you to all of you for giving me the opportunity to join this conversation today about the vital role that research plays in driving quality and ethical care in Northern BC. I'm trusting that you are seeing my screen, right? Yeah. That's good? Okay. So my name is Esther Alonso, and I am the lead of Northern Health Ethics Service. I would like first to acknowledge that Northern BC is home to many distinct Indigenous peoples, each with unique languages, cultures, and governance systems. And these nations have lived in deep relationship with the land for thousands of years, and their enduring wisdom actually invites us to reflect on our own connections to nature, community, and humankind. I would also like to clarify that I have no conflicts of interest to disclose, and this work was supported by 2 grants provided by Northern Health in collaboration with PHSA and UNBC. So today I would like to talk about moral distress in healthcare. And hopefully I will be able to show you that we can shift that story from one of suffering to one of empowerment. And I will be able to illustrate that by introducing an intervention that we have developed at Northern Health, which is called Moral Empowerment System for Healthcare. So the issue of moral distress starts with the realization that healthcare is a deeply moral enterprise. It brings together strangers, providers, and patients in relationships marked by trust, vulnerability, and often suffering. And providers hold power through expertise and resources, while patients or clients, they are facing dependence and uncertainty. And additionally, this relationship unfolds within a complex system of ethical, legal, and institutional frameworks. So in this context, you can imagine that it is inevitable to face questions that go beyond clinical and scientific knowledge and are focused on moral considerations. And facing those moral questions and challenges inevitably causes healthcare providers to experience moral distress, that deep moral unease that we call moral distress. In recent years, we have observed that the intensity and frequency of that experience has increased, affecting not only nurses and physicians, but also allied health professionals, leaders, and administrators. And over time, unresolved moral distress can accumulate, leading to burnout, disengagement, and even departure from the profession, which then in turn impacts patient care and the stability of the healthcare system as a whole. So there are no questions. We need to address moral distress. And over time, 2 main types of responses have emerged to address this problem. The first one is focused on resilience, right? So resilience-based approaches, and they aim to decrease providers' suffering. While beneficial, these strategies often overlook the ethical roots of moral distress and place the burden on the individual, ignoring multi-layered factors that are also playing a role, such as the team dynamics and the organizational culture. The second type of approaches are based on education, so to enhance the ability to make ethical decisions. And actually, the results here are more promising. They have the strongest impact on moral distress, but also if they are just standalone sessions focused on individual providers, that impact is going to be significantly limited. So over the past 2 years, we have been working on an approach that, while not perfect, aims to be more comprehensive than previous approaches. And at the heart of this approach is a deliberate shift. Instead of minimizing or aiming to minimize or to avoid moral challenges, we start by acknowledging that they are an inherent part of healthcare. And the goal then isn't to eliminate that discomfort or to make moral challenges disappear, but to navigate those with confidence and clarity. And this is what we call moral empowerment. So creating those psychological and organizational structures of support that build the ethical capacity needed to respond effectively to moral challenges. And we also recognize that to achieve that goal, we need to intervene at 3 levels: the individual, the team, the interprofessional team, and the organization. So the intervention we have developed, called Moral Empowerment System for Healthcare, has then 3 related components. The first component focuses on the individual, and it uses a structured learning program to enhance individual ethical competences and equip staff and leaders with the knowledge, the skills, and the tools needed to navigate moral challenges. The second component focuses on the team, the interprofessional team. And after completing that individual learning program, participants come together in a facilitated team session, and these sessions create that space for open dialogue, for the development of interprofessional competences in ethical decision-making. And the third component is placed at the organizational level. It is focusing on creating system-level supports that can actually enhance the capacity of the organization as a whole to face these challenges. And this includes ethics consultations, structured debriefings, and mentoring groups. So for the second part of my presentation, I'm going to share with you the results of the pilot evaluation of the first two components of the MESH intervention, the individual learning component and the team-based component. So I am aiming to answer three questions. The first question is, does participation in MESH actually impact healthcare professionals' self-reported ethical competences? The second question is, does it impact their self-reported interprofessional ethical competences? And finally, in what ways does the intervention MESH shape their experiences of moral distress and moral empowerment? So to answer those questions, we conducted a pilot study involving 13 participants from 2 interdisciplinary clinical teams. And we designed a longitudinal study that engaged these participants at 4 key time points: before the intervention, during the intervention, immediately after, and 2 months after the intervention. And at each stage, we actually use quantitative and qualitative tools to gather information about their ethical competencies, so they were able to rate their ethical competencies, their level of moral distress and empowerment, and to describe those experiences. And the data was analyzed using non-parametric statistical methods for the quantitative results and thematic analysis for the qualitative findings. So the first set of results is focused on the experience of moral distress. What is causing moral distress for healthcare professionals that were participating in the intervention? A common theme was conflict with patients' with patients and their families, particularly when family decisions seemed to contradict what providers believed was in the patient's best interest, or when emotional reactions from families left providers feeling personally attacked or professionally inadequate. So, for example, one participant shared, the reactions of the family are strong, and as providers, we either feel hurt or feel like we didn't perform well. Ethical tensions also emerge around the allocation of scarce resources, where participants struggle to balance equity, compassion, and systemic constraints. So one participant said, I think there is a feeling of helplessness in terms of what we can do for our patients, not being able to complete your practice in the way that you should or feel like you should, because I don't have the means to do that. Overall, participants described this experience of moral distress as overwhelming, accompanied by disillusionment and hopelessness. One participant even said, I'm so morally distressed, I don't want to be a healthcare professional anymore. So now let's turn to the good news part of the presentation. So this graph that you are seeing on your screen is showing you how participants rated their ethical competency skills before, represented with the blue bars, and after the intervention, represented with the red bars. And participants did report an increased confidence in their ethical competencies after participating in MESH. Even in some aspects of ethical competency, such as identifying an ethical issue, identifying the decision makers, the ethical duties and obligations, the potential actions, and across all those particular factors of ethical competencies, the increase after the intervention was high enough that it reached statistical significance. The qualitative data we obtained during and after the intervention also allow us to explore the experience of moral empowerment. So individually, people described a shift in how they saw their professional impact. They also described they engage in a deeper self-reflection around their personal identity. And participants also reported enhancements in their reflective practice, moral courage, and perspective taking. So for example, they say, I can ask myself now whether this is something I want or something that is really morally right or wrong, or now I know I need to speak up regardless of my level of training. So at the collective level, as an interprofessional team, participants expressed they were able to build stronger connections and mutual supports among the team members, enhancing their ability to reflect together as a team. So for example, one of the participants said, my team now is more aware of how to deal with ethical issues in a constructive way. Oops. So after the intervention, 2 months after the intervention, participants were reporting a sustained impact on clinical practice. What is going on with are you seeing my screen?
Yes, we can see your screen. It's sustained
Okay.
impact on clinical practice, and there is a quote from a person.
Okay. Yes, so 2 months after the intervention, they were saying, I do use a lot of the learnings in my daily practice and feel that they have helped me apply a different lens to some situations that previously I wouldn't have. Participants also expressed that the intervention was a potential foundation for changing the organizational culture. And finally, we also have to recognize that they expressed it is not a miracle pill, right? For example, one participant expressed, I was hopeful, but still some team issues are not resolved. So what did we learn from this pilot study? Well, in general, we learned that the intervention, this moral empowerment-based intervention, helped individual participants and teams to enhance their ethical competencies, skills, and feel morally empowered to navigate moral challenges. At the collective level, it also enhanced their interprofessional ethical competencies. But we also learned that change doesn't happen overnight. To realize the full potential of MESH, we need to expand to other areas. We need leadership involvement and also the commitment of the whole team. So currently, we are still enrolling more participants to proceed to stage 2 in this project. We have now 20 new participants enrolled, and we are advocating to secure funds to expand. I would like to thank my collaborators from Northern Health, PHSA, and UNBC. And with that, I would like to open the floor for questions.
Fantastic. Thank you so much for that tour de force of a presentation. Very, very insightful. We open it up for questions. Anybody who wants to ask, go ahead, Benita.
Hey, Esther, thank you so much. That was so interesting. How do we, you can see the successes there. And I think someone said once, Canada's the land of pilot sites. We do these pilots, right? How do you see next steps to keep promoting this? You mentioned you have continuing enrollment, but how do you see supporting further implementation of this?
That's a very good question. I was in that presentation where they said that Canada is the land of pilot studies. So I'm very much committed to this, to develop this intervention and to continue rolling it out. Actually, to approach this from a research perspective has proven very successful in the sense of securing resources to expand the work, right? And this is the route that I have been. Anyways, I was going to frame it as a research project because, of course, we need to test that the intervention actually works. So we will be using the scientific methodology to do that. But to frame it like that also help us to secure some funds and commitment and passion. Unfortunately, I have to say that. So in addition to that research approach, and securing funds through grants, commitment and passion. I have found a lot of people who are very passionate about this work, and we are pushing it forward.
Fantastic question and fantastic answer. There is no substitute for passion and commitment in some of these difficult questions and areas of inquiry that are necessary for developing and improving the quality of care that we have. Anybody else with an additional question or comment? So if I can take the liberty as the host to ask, like an additional question to Benita's. So now you know that, knowing that Canada has been framed the land of pilot, and I think pilots are probably much more inherent in smaller places. Most times it's related to funding. Most times it's related to priorities. If you don't have pilot data, they will not fund the major study. If they fund pilot data, they may not be funding for the major study. How do we reconcile this? What is the formula? Do you have some thought into how can we make this a perpetual thing?
You are asking me to solve the research and healthcare problem. To be honest, what is coming to mind is a commitment from the organization. I believe that the organization, especially when we talk about research in the context of healthcare, right? Research in action. If you have the commitment from the organization, I think that you will be able to pass that stage of pilot projects to some extent, recognizing that sometimes budgets, of course, are limited, and we have to deal with that as well. But commitment from the organization is number one. And then we need to continue the dialogue with those research funding agencies to advocate for more support in order to pass that stage of piloting.
Yeah, great. And there's a great comment from Viola there that what you have demonstrated is not just research in action, but research as action. And I support exactly what you mentioned as a clinician, but also as a researcher. If I may take the liberty to just add to what you say, that most times organizationally, if people are committed, not just researchers and clinicians, but organizations are committed to move the ball forward, this can happen. And I think in your case, you have very powerful data and qualitatively people telling you what their fears are, how this has helped them. That can also be a powerful message or a powerful way to motivate, if you will, organizations and funders. So I'm very glad and thank you. If anybody else has a final question, final thought, otherwise I would like to take. Oh, go ahead, Benita.
I do. I have one more question. Esther, do you think this is successful? Like, do people have to want to do it and be drawn into it versus, like, say you're hearing of a team or a ward that's having, real challenges and, challenges with the families, and, you might recommend this as an intervention, but then it's kind of being put on them as something they should do. Like, do you think, that can work, or is it really need to be something that people have to be kind of interested and want to go attend and do?
Yeah. Yes, they need to want to do it, because the program, the individual component of the program is also focused around individual moral development and growth, right? To expand your moral perspective, your moral worldview. And just only through that expansion, you are able now to feel empowered to actually address those moral challenges, right? If people don't want to go there, if people don't want to push themselves, they are not going to get anything out of the program. They're just going to be there and for 1 hour and that's it, right? So they need to want to be there, to be present. And the other thing that it has represented a big challenge for us is they also need to have some level of hope left, right? because we have heard from people, I'm not going to enroll because nothing is going to change. Why to bother, right? I'm so overwhelmed that I don't have time for one more thing. So people also need to have that initial state where they are still hopeful, they are still motivated, so that they are able to find that time and to enroll. So it is an intervention that is successful, it is very promising, but we need to deploy the intervention before people reach that level of burnout that they are about to leave the profession or to leave the organization.
I'm going to have to cut the interesting conversation. Thank you, everybody. Thank you to our speakers, and thank you to the audience. Really, really wonderful session. Thank you so much for making this a fulfilling and engaging 1 hour of our time. So I'll, with that, end this session, and everybody else, we will see you in other of these sessions. Thank you so much.